What I'm going to be talking about today is hypersomnia. Hypersomnias that have an underlying neurological basis, although I will deviate a little into the realm of psychiatry, largely to raise some issues that I think are deserving of further attention or deserving of further exploration. So I'm going to really start by focusing on narcolepsy, which is the archetypal hypersomnia, which I think many of you will be familiar with, but perhaps not in a huge amount of detail. I'm going to also discuss an associated condition called idiopathic hypersomnia, and also Klein-Levin syndrome, which is a rare neurological disorder that will sit within the differential of some of the patients that you will see in psychiatric practice. So, as I said, I'm going to start off with narcolepsy. This is a rare condition in general terms, but in neurological terms is not that rare. So we estimate that within the UK, about 1 in 2,000 individuals have narcolepsy. There is huge geographical variation, which raises the possibility of an underlying genetic contribution. It's said to be much more common in Japan, up to about 1 in 600. In Israel, it's extremely rare, about 1 in 500,000. It's one of the few disorders that being Jewish actually protects you from. The reality is, therefore, that given that the prevalence is 1 in 2,000, the average DGH should have tens, if not at least 100 patients with narcolepsy. But if one actually trawls through the records of the average DGH, there will be perhaps 5, suggesting that there's a huge number of individuals out there with narcolepsy who are undiagnosed. It's a condition that affects males and females equally, and in keeping with our developing thoughts on etiology, it has an increased incidence. It has 2 major incidence peaks, one at around the age of about 15 or 16, and these 2 graphs are for narcolepsy with cataplexy and narcolepsy without cataplexy, and then the second peak is in the mid-30s. You know, very similar to what we see with other conditions. So what are the clinical features? Well, I think you'll all be very familiar with many of these features. So what it boils down to is that individuals with narcolepsy have a breakdown of the boundary between wake and sleep, but they also have a breakdown in the boundaries between non-REM sleep and REM sleep. REM sleep, of course, is the stage of sleep which we most strongly associate with dreams of a narrative structure, during which our EEG looks rather similar to the waking EEG, but our muscles are completely paralyzed. We develop significant atonia of all muscle groups, the exception being the muscles of respiration and the muscles that allow us to move our eyes from left to right, which is why the term rapid eye movement sleep has come about. And then non-REM sleep is this stage of sleep that comprises light and deep sleep, during which we see slowing of the EEG, and it's the stage of sleep that we most associate with restoration of function. So if individuals have an instability between these boundaries between wake and sleep and non-REM sleep and REM sleep, it becomes a little easier to contextualize their symptoms. And these 4 symptoms, these 4 features, are the cardinal tetrad of narcolepsy. So the only mandatory criterion is that of excessive daytime sleepiness. So either a persistent sleepiness throughout the day, or as is commonly held to be the case in medical and non-medical circles, is that narcolepsy presents with dramatic sleep attacks. Now, that is the case in some individuals. It's not the case in everybody. Other features include hypnagogic or indeed hypnopompic hallucinations, which we think relate to REM sleep or dreaming mentation at the boundaries between wake and sleep. Sleep paralysis, which is the persistence of the REM atonia that is a normal feature of REM sleep persisting into wakefulness. And then finally, cataplexy. And I'm going to go on to discuss these features in a little more detail. So, as I've already said, the excessive daytime sleepiness in narcolepsy is the only mandatory symptom for the diagnosis of narcolepsy. Anything else is a plus, but the only thing that you need to meet the diagnostic criteria is of excessive daytime sleepiness that is present on a daily or near daily basis for the more than 3 months in duration. These can be discrete sleep attacks. They can be really rather dramatic. I've had patients who've fallen asleep whilst in goal, waiting for a penalty to be taken. I've had individuals who've fallen asleep during sex. So really, these sleep attacks can be incredibly dramatic. But actually, a more common picture is of somebody who has persistent sleepiness and then every so often feels the need to go to sleep, but it's not to the point where they fall asleep exactly there and then. They will often retreat to the sofa, they'll retreat to a toilet cubicle at work, for example, and have a short nap. Typically, these naps are indeed short, so if people are napping for more than an hour at a time, that's a little bit unusual for narcolepsy and raises a small red flag, and those naps are typically refreshing. So individuals will frequently say, I will close my eyes for 2 minutes, fall asleep, and when I wake up, I feel very refreshed, and that keeps me going for a little while. And interestingly, in the majority of individuals with narcolepsy, their total sleep time per 24 hours is normal, or perhaps a little bit longer than it otherwise should be, but not excessively so. And I think this once again reflects the fact that they have difficulty stabilizing wake and sleep during the day, but they also have difficulty stabilizing sleep overnight. So one of the features of narcolepsy that is very infrequently described is the fact that these individuals will often complain bitterly of very fragmented, broken sleep with prolonged periods of time awake at night. And this does create some diagnostic issues in some individuals who clearly do have narcolepsy. It's often blamed on the quality of their nighttime sleep, and it's viewed to be a feature that points away from narcolepsy, whereas in actual fact, poor nighttime sleep is entirely consistent with a diagnosis of narcolepsy. So what about cataplexy? So, well, cataplexy, as I'm sure you'll be aware, is this description of a sudden temporary loss of muscle tone that's precipitated typically by positive emotions like laughter and joking. Many of my patients describe the cataplexy to be precipitated by an internal feeling of mirth. So what they mean by that is that when they're telling the joke, where they're the origin of the humor, it's at the point where they're just about to deliver the punchline that the cataplexy kicks in. Cataplexy is not a universal feature of narcolepsy. It is seen in about 60 to 70% of patients with narcolepsy. And I'm going to go on to discuss the distinction between the two categories a little bit later on. It is usually present after, or so in many cases of narcolepsy, cataplexy tends to come on at roughly the same time as the excessive daytime sleepiness, but it can sometimes occur many, many years after EDS. It's very unusual for cataplexy to precede the other of narcolepsy. And I think that these two next points are really very helpful in terms of understanding cataplexy. So in the popular imagination, cataplexy manifests as a sudden collapse to the ground when people are laughing or experiencing strong emotion. Actually, that is really quite far from the truth, in that only in about a quarter of collapses is first of all, cataplexy, a generalized form, resulting in loss of muscle tone throughout the body. The second feature, important feature of cataplexy, is that the loss of muscle tone is actually not persistent. It's almost like negative myoclonus. So individuals will experience a very brief loss of muscle tone before their tone will return to normal. And what you see is almost like a jerking, a negative myoclonus that results in a progressive, gradual weakness, which often leads to individuals being able to lower themselves to the ground before they completely lose muscle tone and prevent injury. Actually, injury in cataplexy is relatively unusual. And the other final important feature and this very much, it comes to the fore when making a diagnosis, is that for many patients, in fact, the majority of patients, the loss of tone is usually segmental or partial. So individuals may not describe loss of muscle tone in the legs resulting in collapse. They'll frequently describe facial atonia, so they will get ptosis, they will get a slackening of their face, they will get some atonia of the tongue, so they will slur the punchline of the joke, for example, or the head will nod repeatedly as they develop segmental cataplexy in the muscles of the neck. These events tend to last seconds to minutes. It's very rare to see cataplexy lasting for anything more than 2 or 3 minutes. There is the exception of status cataplecticus, which is this phenomenon whereby individuals who've been established on anti-cataplectic agents suddenly have that agent withdrawn, and then they go into a sort of a persistent cataplectic state. And crucially, once again, from the point of view of a differential diagnosis, individuals with cataplexy retain full awareness. They do not in any way experience a change in their awareness. They may describe not being able to see because of the ptosis, but they will hear everything that's going on around them, and they may well be able to partially respond during these events. The exception to that is very prolonged episodes of cataplexy, where individuals occasionally may start entering into REM sleep and may experience some hallucinations associated with REM sleep. And one of the helpful features is that during cataplectic events, individuals will lose their deep tendon reflexes. So as a sleep physician and as an epileptologist, I rarely wield a tendon hammer, but I tend to have one in my clinic. So should somebody have a cataplectic event, I can check whether or not they have indeed lost their deep tendon reflexes. And this is a really good illustration of cataplexy. So this is the neck EMG, and you can see these very small periods of essentially radio silence, which is this sort of negative myoclonus, this period of atonia, and these little small periods of atonia tend to get longer and more frequent as the cataplectic event continues. So what does cataplexy look like? Well, this is a good example in a dog, and the reason why dogs are so relevant to this story. Can you hear that? Tim, can you hear the sound? No. Can I just try and let me just come out 1 second, try and see if I can get the sound working.
Skeeter is a small dog with a very big problem. No matter how much he struggles to stay awake, he can't. For this 11-pound toy poodle, almost every moment is a disturbing, losing battle with the urge to sleep.
So what you can
Skeeter is a small.
What you can see very nicely there, I'm not sure if you managed to hear the commentary. It's this sort of very brief loss of tone, predominantly in the hind legs. It wasn't that the dog was collapsing to the ground completely, although with some of his events later on in that video, Skeeter was losing complete muscle tone and was unable to sustain any sort of posture. This is a patient of mine who describes a very nice
that I feel is funny. So it's an emotional connection.
Head nodding,
the first event
which is
that
really
ever
rather
happened
typical.
was trying to put the children to bed.
And I don't know if you want to see that again. So the head nodding, the ptosis, the fact that he can to some degree sustain some tone even when he is in the midst of his collapse.
It's any event that I feel is funny. So it's an emotional connection. The first event that ever happened was trying to put the children to bed.
And actually, this is a really good example of segmental cataplexy. This is a video from Matthew Walker at Queen Square. So what you can see is she's having some difficulty supporting her head. And you can see some little bits of ptosis coming in, and she's losing transient tone in her left arm as well. And then Matthew says something that she finds a little bit funny, and then her head just flops back. So sometimes cataplexy can be very subtle indeed, and it's actually these more subtle forms that are more helpful diagnostically. The reason why I stress this as being so important is that cataplexy or cataplexy-like events are not unusual in normal individuals, and they're not unusual in individuals with other sleep disorders. So actually, when people say I go weak at the knees when I laugh, that's a very common normal phenomenon. In fact, there is an electrophysiological reflex that can be demonstrated in normal individuals with changes in those deep tendon reflexes occurring alongside. In this very nice study, which was done by Claudio Bassetti, who's a sleep neurologist based in Bern, he demonstrated that 8% of normal individuals will report some cataplexy-like symptoms, and about 18% of people with sleep disorders, non-narcoleptic sleep disorders, will also complain of cataplexy-like events. So actually, that's why it's so important to take the time to understand the semiology of apparent cataplexy-like events in these individuals. So what about the hypnagogic hallucinations and the sleep paralysis? Well, these occur in between 1/3 and 2/3 of individuals with narcolepsy. They are predominantly visual. So the classic hallucinations that individuals will describe is animals in the room or figures standing over the end of the bed, occasionally intruder type hallucinations. They can occasionally be auditory as well, but they tend not to be multimodal. They're brief lasting. These hallucinations can be more bizarre, especially if associated with sleep paralysis, in that individuals will often describe out-of-body experiences or sometimes being assaulted, because if you imagine that you're having dreamlike mentation at the same time as being paralyzed, that sensation of paralysis is often likened to being held down or having a weight on your chest. And that's probably because the muscles, the accessory muscles of respiration, are also affected by REM atonia. And so if you feel chest heaviness, you feel that you can't move, then that can be integrated into your dream mentation and can manifest as being assaulted or held down. There are, of course, a whole host of other clinical features in narcolepsy. So one thing that is very little recognized is that many individuals with narcolepsy will describe REM sleep behavior disorder, so that during REM sleep, when they are dreaming, that those mechanisms that underlie the development of REM atonia don't fully work, and so therefore they will exhibit dream enactment behavior, typically things like laughter or talking or shouting out in their dreams. To individuals who have alpha-synucleinopathies or in the prodrome to conditions like Alzheimer's disease or dementia with Lewy bodies, a REM sleep behavior disorder in narcolepsy tends to be less violent. The other feature which I find fascinating is that individuals with narcolepsy, between 70 and 80%, describe the ability to lucid dream, so that they can maintain a degree of awareness or occasionally feel that they control the narrative of their dreams. So one of the other things that they often describe is that they will be able to wake up in a dream, that dream will continue in wakefulness, then they will go back to sleep again, and that story will continue to unravel. Many individuals also report automatic behaviors, so the kinds of things that we associate with being very tired, so putting socks in the fridge, misplacing your keys, putting your mobile phone in the oven, or actually simply just writing a whole load of gibberish when you're taking notes in class or in a lecture. And then there are a whole range of other sleep disorders and also depression, which seem to go hand in hand with narcolepsy. So what about the etiology and the pathophysiology? Well, this is a remarkable transformation in our knowledge of a particular disorder. The canine model, going back to Skeeter and his friends, was first described in 1973, and in the 70s and 80s, Stanford in particular Emmanuel Mignot, developed a breeding program for dogs with a genetic form of narcolepsy. Eventually, after about 20 years of work, they identified that at least in the dog model, there were mutations in a gene that encoded for a particular neurotransmitter receptor, which was subsequently named hypocretin 2. But this mutation was not demonstrated in sporadic forms of canine narcolepsy, where they found that this neurotransmitter was reduced in terms of its levels in the CSF. And it was about the same time that in humans that cells were identified in the lateral hypothalamus that produced this neurotransmitter hypocretin, that projected extremely widely throughout the brain, particularly to the locus ceruleus, the TMN, and various other nuclei that are involved in arousal states. So when humans with narcolepsy were screened for these mutations in the hypocretin receptor gene, this was not found to be the cause for the majority of individuals. There has subsequently been a familial example of narcolepsy with 2 individuals affected who have been demonstrated to have a mutation in this particular receptor. But actually, subsequent investigation demonstrated that in individuals with narcolepsy with cataplexy in particular, there seemed to be a significant loss, between 90 and 95% loss of these hypocretin producing neurons within the lateral hypothalamus. And indeed, subsequent studies demonstrated that the majority of individuals with narcolepsy with cataplexy, when CSF hypocretin levels were measured, demonstrated themselves to be deficient or entirely absent of CSF hypocretin. Why should this manifest in terms of the symptoms of narcolepsy? Well, we know that actually one of the major functions of this nucleus in the lateral hypothalamus is really to promote wakefulness and to stabilize non-REM sleep. So in individuals who have loss of these hypocretin producing neurons, then the projections down to these nuclei that promote wakefulness no longer exist. And when we are asleep, we tend to favor going into REM sleep rather than non-REM sleep if we lose these hypocretin producing neurons. So one can begin to understand why the loss of these hypocretin producing neurons might result in the symptomatology that exists in narcolepsy. What about the genetics? Well, genetics is certainly not the full story. We know that the risk for a first-degree relative with somebody with narcolepsy of also developing narcolepsy is about 1 to 2%. So it is very significantly higher than the prevalence in the general population, but certainly does not point towards genetics being the only answer. We know that in twin studies, only about 1/4 to 1/3 of monozygotic twins are concordant for narcolepsy. So clearly there is a genetic contribution, but it's not the only answer. Perhaps one of the biggest clues comes from this association between narcolepsy with cataplexy being very strongly associated with this particular HLA type called DQB1*0602. And this is by far the strongest association between any human condition, any human disease, and any HLA type. So between 95 to 98% of individuals with narcolepsy with cataplexy are positive for this HLA type. So really suggesting that there is an immune or autoimmune contribution to this disorder. And there are some other clues that our immune system may be involved. There are associations between the incident or the onset of narcolepsy with a peak in March and a trough in September, which suggests that there might be environmental factors at play, but it's not direct infection that seems to be what is causing the disease. It may well be an immune-mediated response to infection. And what do genetics tell us? Well, actually, the strongest genetic association between narcolepsy with narcolepsy, apart from the HLA type, is this T cell receptor alpha gene variant. And this really very much points towards there being some sort of T cell mediated process that might be responsible for the origins of narcolepsy. And as many of you will be aware, in 2009 and 2010, when we were very fearful of another pandemic, the H1N1 swine flu pandemic, there was a massive spike in cases of narcolepsy, particularly in children, but also in adults, associated with one particular H1N1 swine flu vaccine, the Pandemrix vaccine, suggesting that certainly there is an environmental infectious or para-infectious process that might be triggering an immune response. And over the last year, so these are the relative risks associated with the Pandemrix vaccine in children and adults. In children, the mean estimated risk of the Pandemrix vaccine is a 10-fold increase. That's much smaller in adults, and it's probably of about 3. These 2 papers, which have both been published in the last 2 years, have now really got to the point where there are still some questions as to the association between this vaccine and indeed other infectious triggers for narcolepsy. But essentially what they've demonstrated now is that in individuals with narcolepsy with cataplexy, there appears to be an expanded population of both CD8 and CD4 positive cells that are responsive to epitopes that are seen in the H1N1 virus. And so our current model, and it's almost got to the point where it's no longer a model, is that individuals with a particular HLA type have a predisposition to generating a CD4 and a CD8 mediated immune response to an environmental trigger, an epitope that mimics either hypercretin or epitopes that are also expressed within those hypercretin producing neurons. And so this is essentially an autoimmune condition as a result of direct damage, immune mediated damage to the hypercretin producing neurons. So we've gone over a period of about 35-40 years to having no fundamental understanding of this condition, to really understanding its pathophysiology, its etiology extremely well. So how do we conceptualize narcolepsy now? Well, it's divided in the latest iteration of the diagnostic criteria into type 1 and type 2 narcolepsy, which I think really does reflect our increased understanding of the pathophysiology. So type 1 narcolepsy are individuals who have the mandatory criterion of excessive daytime sleepiness. They either need to have a diagnostic MSLT and cataplexy, or they need to be demonstrated to be deficient in CSF hypercretin. Type 2 narcolepsy are those individuals who have a diagnostic MSLT but no definite cataplexy, and that their CSF hypercretin is either normal or not done. And I think that this really reflects the fact that we understand that there are some individuals who don't have cataplexy but will go on to develop cataplexy subsequently, who are essentially the same diagnostic category as those individuals with cataplexy already, whereas there are other individuals within that narcolepsy type 2, what used to be termed narcolepsy without cataplexy, who perhaps have a range of other conditions that mimic narcolepsy, and there remains some ongoing debate as to what those conditions actually are. So I think I've already discussed this slide, so I'm going to skip it. I'm going to show you a few cases to illustrate some of the diagnostic issues. So the first is a 27-year-old woman who described very poor sleep, very prominent hypnagogic hallucinations, and sleep paralysis for several years, but she did not report cataplexy. When she came in for a sleep study, She slept for just over 6 hours on a sleep study, and her mean sleep latency test was diagnostic of narcolepsy. So for those of you not aware, the diagnostic criteria are a mean sleep latency over 4 or 5 naps of 8 minutes or less, and at least 2 SOREMs, so entering into REM sleep within those brief naps. So she clearly demonstrated a diagnostic MSLT, and according to the diagnostic criteria would meet the a diagnosis of narcolepsy type 2. But actually, when we recorded her sleep at home on an ongoing basis, it demonstrated that she had really a very poor sleep and was very chronically sleep restricted. So when she was sent for cognitive behavioral therapy for insomnia and was instructed to extend her sleep opportunity, her symptoms completely resolved. So why do I show this case? Well, it's really to illustrate some of the limitations in the diagnostic testing that we have. The MSLT, which is what we routinely do in the sleep lab, is a biological test, and it has a significant false positive rate and also to some extent a false negative rate. It has some procedural issues. So what I mean by that is, for example, when the sleep lab used to be at St. Thomas's, people used to be woken up on the hour every hour by Big Ben, which was not particularly conducive to a standardized test. Individuals may be allowed to consume caffeine between naps or smoke between naps, which they really shouldn't do. There are many environmental factors that may influence the validity of the sleep test. The other, perhaps more important issue is that we know that there are a range of other conditions that can give rise to a positive MSLT. So in particular, individuals with circadian rhythm abnormalities or individuals who are chronically sleep deprived. And in one study, which was done by Migno about 20 years ago, he demonstrated that about 6% of males and over 1% of females had a test that apparently looked like narcolepsy without there being any clinical features of narcolepsy. So the reason why I stress this is that if the diagnosis is based upon the MSLT alone, you're about 70 times more likely to misdiagnose somebody who's chronically sleep restricted as having narcolepsy than truly diagnosing somebody with narcolepsy. So what I would always stress is that the MSLT is an extension of your clinical evaluation of the patient, a little bit like the use and abuse of the EEG in epilepsy, that the EEG can be supportive of a diagnosis of epilepsy, but should not be the sole thing upon which a diagnosis relies upon. And this illustrates some of the other issues with the MSLT, in that the test-retest reliability is very, very poor. So in this study, they took a number of individuals, put them through an MSLT, made a diagnosis on the basis of that MSLT, and then retested them to see if the diagnosis changed. And perhaps what's most striking is that in this group of individuals, at the end of the first MSLT, 15 individuals were diagnosed with narcolepsy without cataplexy, of whom by the time they'd had their second MSLT, the diagnosis only remained unchanged in 5 out of those 15. So once again, stressing that to rely on the MSLT to make a diagnosis purely is a very dangerous thing, particularly when you've got a condition that essentially is a lifelong condition that requires lifelong treatment. And a bulk of my clinical work actually is in reversing the diagnosis of narcolepsy that's been made in individuals historically on the basis of this sort of testing. So we know that there are some interesting features on the MSLT that can help us firm up a diagnosis of narcolepsy. So this is a Swiss study and some follow-up studies by our own group, which demonstrated that actually individuals with narcolepsy have a tendency to go into REM directly from stage 1 or from wake, suggesting really quite significant REM instability, whereas in individuals who are sleep deprived, that tends to be much less the case, and they tend to go into REM from deeper stages of sleep. So this is another case. This is a 44-year-old woman who had a long preceding history of anxiety and depression. She presented with a history very consistent with narcolepsy type 1 in that she had very convincing cataplexy. She described a collapse when crossing a road, and as she was crossing, she was honked at by a driver, and the shock of it caused her to collapse to the ground, which was the reason for her to seek medical attention in the first place. She underwent actually 2 sleep studies, both of which were negative, but because of the clinical picture, we organised a CSF hypocretin, and of course she was entirely deficient of hypocretin, confirming a diagnosis of narcolepsy. So I think, once again illustrating that there are also false negatives in these cases. So is CSF hypocretin the gold standard? Well, it certainly is for narcolepsy type 1. The slight difficulty is that if you take individuals without cataplexy, only about 40 to 50% of individuals will be deficient of CSF hypocretin. So if somebody does not have cataplexy and their CSF hypocretin is normal, that does not rule out diagnosis of narcolepsy. This is a 23-year-old woman who was referred up from another centre in the West Country with a diagnosis of post-H1N1 vaccination narcolepsy with cataplexy. She'd been vaccinated in 2009, and she began to experience significant excessive daytime sleepiness in a few months after that. She described disturbed nighttime sleep, vivid nightmares, daytime flashbacks, and a whole range of other symptoms very strongly suggestive of narcolepsy. She had significant sleep paralysis. But the reason why she was referred was because about 5 years after the onset of her symptoms, her legs began to buckle whilst she was walking. She had gradual worsening and continuing buckling, which precluded her walking without crutches. She'd been diagnosed with this condition status cataplecticus that I mentioned earlier on in the talk, and had been started on treatment, which didn't do anything at all. She'd had a sleep study confirming a diagnosis of narcolepsy, but had not had any further diagnostic testing. When I saw her and assessed her clinically, she really walked in as if she was bouncing up and down. And interestingly, when she was forced to lock her knees, that bouncing gait resulted in hip rocking, which was entrainable. So when I asked her to tap the table in front of her in a particular rhythm, the hip rocking took up the same rhythm as the tapping, really very strongly suggesting that this was a functional neurological disorder. She went on to have a CSF examination, which was entirely normal. She was profoundly depressed. Her treatment was escalated, which resulted in a significant improvement in her mood. And when the venlafaxine was subsequently withdrawn, her symptoms remained in remission, suggesting that this was essentially a functional neurological disorder or pseudo-cataplexy. So I'm just going to talk a little bit about some of the psychiatric causes of excessive daytime sleepiness, because, at medical school, we're obviously taught that early morning waking is a biological feature of depression. I think all of you will be far more familiar than I am that there appears to be a subgroup of individuals with depression who are profoundly sleepy. And in those individuals, about a quarter, when their sleep is assessed formally, objectively in a sleep lab, will have really quite profound objective sleepiness to the extent that it falls within the diagnostic realm of narcolepsy. And indeed, the other feature on the sleep study that we utilized to make a diagnosis of narcolepsy, which is the early onset of REM, is reported in about 20 to 30% of people with depression, especially the elderly and especially those who exhibit psychotic depression. So this can be a major confounder when it comes to making a diagnosis of narcolepsy, in that if somebody is profoundly depressed, it's very difficult to rule out psychiatric hypersomnolence. What about other functional symptoms? Well, pseudo-cataplexy is well described. We do see quite a number of individuals who exhibit what is originally thought to be cataplexy that is subsequently understood to have a psychiatric or a functional basis. When it comes to individuals who have what we term pseudo sleep or functional sleep, there is surprisingly very little literature in the psychiatric journals. Many of the papers that I found really date back to the 1950s and 60s, and there's very little subsequently about these individuals who exhibit functional sleep attacks. There are indeed large cohorts of individuals who complain bitterly of subjective sleepiness without objective measures when measured in a sleep lab. And I think, for example, of the individuals with postural orthostatic tachycardia syndrome who often complain very vociferously about profound sleepiness, but that can never be objectively determined. We see a number of individuals who in our service who are diagnosed with idiopathic hypersomnia or some other form of hypersomnia that have personality disorders. And once again, this is very poorly described. We've had a couple of individuals who have been clearly malingering. So I can think of one individual in particular who developed profound hypersomnia, sleeping for 16 to 17 hours a day with the birth of his first child. It was when he was threatened with an admission to the Leishman unit that all of a sudden his sleepiness vanished about 3 days before that admission was due to happen. And obviously this association between sleep and non-organic pathology may simply represent bias within our own service, but I think it's far more common than any of us appreciate. It's surprisingly poorly described, and I think it really does deserve some more attention. So if anybody at SLAM wants to look at this in a bit more detail, I'd be very eager to do that, because I think it is clinically an important area. I'm going to, how am I doing for time, Tim?
We've got about 15 minutes left, but it'd be nice to leave some time for questions if you can. Another 5 minutes would be good.
So I think I'm going to skip the last cases, only to say that there are some obvious symptomatic cases of narcolepsy. So the kinds of conditions that can cause narcolepsy are autoimmune disorders, paraneoplastic disorders, certain genetic syndromes, tumors of the hypothalamus, inflammatory lesions of the hypothalamus, like, for example, neuromyelitis optica, which seems to have a particular predilection for the hypothalamus, and conditions like Wernicke's, for example. So this represents a case of Wernicke's, somebody with a hypothalamically based tumor and somebody with neuromyelitis optica. I'm just going to touch very briefly on idiopathic hypersomnia and Klein-Levin syndrome. So idiopathic hypersomnia defines a group of individuals who have persistent sleepiness no matter how much they sleep. So this is at least symptomatically rather different from narcolepsy, in that these individuals will often have very long sleep durations, anything between 11 and 16, 17, 18 hours. No matter how much sleep they get, they will feel unrefreshed. They will often be very sleepy during the day, and when they sleep, they will typically sleep for more than 2 to 4 hours. Once again, their daytime sleeps are completely unrefreshing. There are, unlike narcolepsy and unlike Klein-Levin syndrome, there are no pathognomonic features. And there remains some doubt about the accuracy of the MSLT in making this diagnosis. At the moment, there is no clear biological marker for this syndrome. So this is a very poorly understood condition that is said to be significantly rarer than narcolepsy. These are really the individuals who we frequently end up coming to a psychiatric diagnosis in, and that the majority of individuals who are referred in with idiopathic hypersomnia either have significant untreated depression or a personality disorder, although there is a small group, a minority, in whom no other underlying explanation can be identified. And those individuals typically have, as well as the excessive daytime sleepiness, have associated autonomic symptoms. So they complain profoundly of headache and of sleep drunkenness on waking, as well as general fatigue. These individuals are often treated along the same sort of lines as narcolepsy with stimulant medication. Now, my own view is that these individuals, even if they do have an underlying psychiatric diagnosis, okay, we should not be labeling them as idiopathic hypersomnia. We should be labeling them as hypersomnia due to a medical psychiatric disorder or occasionally due to drugs. But that doesn't mean that they don't warrant treatment. If their psychiatric state has been treated as aggressively as it possibly can be, and they remain profoundly sleepy, then I think there is a case for treating them, because often treating their hypersomnia also helps to address their underlying psychiatric condition as well. Obviously, there are provisos to that, in that what you don't want to be doing is giving them stimulant drugs that might worsen their neuropsychiatric status. There's been relatively little research in the area of idiopathic hypersomnia. There have been some studies that have come out of Emory in Atlanta in Georgia that have suggested that there may be some endogenous GABAergic factor that somehow enhances the effects of GABA on the sleep promoting centers in the brain. They have given individuals with idiopathic hypersomnia treatments like flumazenil and have demonstrated an improvement with vigilance, although they've never clearly demonstrated an improvement in terms of objective levels of sleepiness. And there remains a degree of skepticism about some of this work, but certainly there is at least a suggestion that these individuals may respond to flumazenil or indeed erythromycin. Now, they argue that erythromycin has some effects on GABAergic transmission. In the past, when I've tried erythromycin in my patients, I've succeeded in causing torrential diarrhea, but very little improvement. When I've taken erythromycin myself, I've had terrible insomnia. So it appears that erythromycin may well be a wake-promoting agent, whether or not you've got idiopathic hypersomnia, and it may have very little to do with the GABAergic system in these individuals. So what about Klein-Levin syndrome? Well, Klein-Levin syndrome, many of you will be very familiar with. This is a condition that was originally thought to be almost exclusively male, although we now understand that gender difference perhaps is not as marked as was originally described. These individuals tend to experience onset in their teens, although the onset of Klein-Levin syndrome has been described well into the 70s. These individuals or the condition is characterized by recurrent hypersomnia, which tends to last days or weeks. These bouts of hypersomnia are accompanied by associated symptoms like compulsive eating, sexual disinhibition, confusion, depersonalization, dissociative features, hallucinations, depressions, and anxiety. They follow a rather typical picture, in that the first few days will typically be of profound hypersomnia, and then as the bout progresses, the hypersomnia will be less severe. They will experience more dissociation, and as the bout comes to an end, they'll experience 2 or 3 days of significant insomnia. And these bouts typically last on average about 12 to 13 years, but the longest reported duration is 33 years. In terms of the pathophysiology, well, we don't really have any fundamental understanding of what causes Klein-Levin syndrome. There is some evidence of thalamic and hypothalamic changes on PET in these individuals. We have recently completed a very large-scale collaboration looking at the genetics of KLS individuals, and we've identified a gene called TRANK1, which is also implicated in bipolar disorder, which is interesting in itself because, of course, there are some parallels between Klein-Levin syndrome and bipolar disorder in terms of these recurrent episodes of changes in sleep. There are, of course, some mimics. So we have reported previously individuals who have alternative explanations for recurrent Klein-Levin syndrome. There appears to be a subgroup of individuals who have briefer bouts of hypersomnia, perhaps 2 to 4 days, in whom they have multiple features of migraine. And indeed, when they are treated for migraine, their apparent Klein-Levin syndrome resolves. And I think for the purposes of time, I'm going to leave it there just to allow some opportunities for questions. Thank you.
Thank you, Guy. Fantastic talk through hypersomnias. So just to start off with a question, I think the overlap or differential with functional disorders is fascinating, and definitely something I and others would be very keen to try and look into. Over and above the usual just being a simple differential, and I guess we have functional disorders that can look the same as or mimic perhaps almost every neurological presentation. Potentially surprising, we also know that you can have a sort of organic disorder which can stimulate a functional disorder on top. But I think over and above that, you've got a potential interesting, particularly just thinking through the narcolepsy interaction of emotion prompting symptoms and the sort of mechanism that might be going on there with the, those very interesting emotional states triggering symptoms. And I guess one way of looking at functional disorders, or one potential mechanism, is of a sort of disruptive or maladaptive sort of freeze response for paralysis or emotional overwhelming causing motor symptoms. So perhaps there's even a connection in between. I was just going to ask you to speculate about that, and also if there's anything known about the mechanics of that emotion motion paralysis interaction within narcolepsy, about the actual what's going on in the brain during that sort of very specific trigger.
Yeah, so I think the short answer is we don't know. I think the long answer is that we know that there are some projections from the amygdala to areas of the brainstem that are responsible for mediating the muscle atonia that we tend to see in REM sleep. Now, it is entirely speculative what those pathways are there for, and I think that certainly some authorities have postulated that this has an evolutionary basis in tonic immobility, which is, of course, this freezing or playing dead response in the face of strong fear. And of course, there are some hypotheses relating the smiling or laughter as being part of the fear response. So it kind of ties in nicely from an evolutionary perspective, but I think we're a long way from proving that.
Great. Just one other quick question. I think we've got one in the chat, but others, please put your hands up or post them in the conversation. Another thing, just out of interest, is whether you've seen any sleep disorders associated with COVID on many levels of mechanism that might be going on there. And of course, today being the first time of vaccination, I mean, obviously it seems very unlikely there might be a risk there, but certainly anecdotally I know of people. In fact, myself, when I had COVID earlier in the spring, I did find myself sort of quite hypersomnolent for a few months afterwards. So whether that was just part of post-fatigue sort of recovery or not, but I was wondering if you got any referrals about or starting to see any signal of sleep disorders associated with COVID.
So I think the answer to that is yes, but indirectly. As you know, when COVID first came about, because of the presentation of anosmia as part of it, there was a great deal of concern that this was very neurotropic. And there was a great deal of concern that actually we might see an epidemic of neurological disorders. I think that has not really been borne out apart from in stroke because of this hypercoagulable state. So we've not really seen any signal to suggest that COVID might directly be responsible for neurological sleep disorders. Certainly, COVID indirectly has resulted, and I'm talking now on a population basis, so I've been involved in 2 studies now, one in the UK and one in Egypt, that have very clearly demonstrated that people's sleep has suffered significantly as a result of the stress or the anxiety of the prospect of catching COVID, but also as a result of all the associated lifestyle changes that have occurred. Now, there is a subgroup of individuals who've actually done incredibly well out of COVID, and these are the young individuals who are not so concerned about catching COVID. They don't have the fear of COVID. They've not had the distractions of nightclubs, of socializing, and their sleep has dramatically improved, and they're far less sleep deprived than they previously were. But for the vast majority of individuals, there have been, really quite extensive reports of longer time in bed, poorer quality sleep, very vivid dreams. Now, the vivid dreams phenomenon, I think, is probably part of REM rebound that occurred when people weren't having to wake up very early. But in answer to your question about a direct association, the answer is no, not yet.
Great. And I think it'd be interesting to see, just because I know you mentioned the POTS association and referrals you get, that there's quite a lot of dysautonomia POTS diagnosis in long COVID patients. So that might, and whether sleep is going to be a big part of that clinical presentation, would be interesting to see.
Well, interestingly, I'm seeing that in my neurology clinic. So individuals who have neurological symptoms that are very akin to those described in POTS, but they haven't made their way through to the sleep clinic yet. And I guess that's because they're focusing on the physical symptoms first, and then eventually they will trickle into the sleep clinic.
Yeah. Great. So we had one question from Michael Deckel, which is, are there any major physical comorbidities associated with narcolepsy?
Yeah, so certainly obesity and associated symptoms. Now, we know that one of the other functions, and I didn't talk much about this, is that hypocretin has got other roles apart from just in regulation of sleep. It also has an important role in regulation of appetite and metabolism. And it also has an important role in mediating reward. And so many individuals with narcolepsy, particularly narcolepsy type 1, will put on significant weight. As a result, they will develop obstructive sleep apnea and all the other associated features of metabolic syndrome as well. And so that's probably the commonest. Now, I touched upon depression as being associated with narcolepsy. We think that probably is as a result of the impact on their social and working life rather than directly. And there are some signals from the literature to support that view. And then, there are a whole range of other sleep disorders that are associated with narcolepsy as well.
Great. So I can't see any more questions or hands up, but given that we've got perfectly to 2 o'clock, I'd want to draw it to conclusion there, and just thanks so much, Guy, for a fascinating talk, and to remind people to keep an ear out tomorrow evening on Radio 4 or on Catch Up about the fascinating neuroscience programs he's got coming up. So if you missed the start of the talk, so 9 o'clock tomorrow evening on Radio 4, Guy's got some fascinating neuroscience of the senses discussions that he's part of, and then also his book as a stocking filler for you, your friends and families this Christmas. So thank you, Guy, again for a brilliant talk, and we conclude again. We're starting our talks again next term on the 12th of January, and it's the second and fourth Tuesday of every month, and details to follow via email, but also watch your team's diary invites as well. So thank you again, Guy, for a brilliant talk, and we'll see you all in the new year, and have a good Christmas, everyone. Bye.
Bye-bye.